Hello, guys. Welcome back. Hope everyone's doing well. So, this video is being posted just a few days after your paper 3 exam, 2024, May, June. And the topics which came in your P3 for clinical psychology were there was a question on schizophrenia, there was a question on anxiety disorders, and one on mood disorders. So, what that means is you can expect questions in P4 to come on impulse control and OCD. All right. So these are the two you can expect questions on for paper 4, which is why I'm going to start off with these two. And then gradually I'll add videos on the other chapters as well. So let's begin the chapter on impulse control disorders from clinical psychology. Okay. It's a pretty short and easy chapter. So let's get right into it. Now, the thing about the chapters in clinical psychology, there are 5 in total: schizophrenia, mood disorders, impulse control disorders, anxiety and fear related disorders, and obsessive compulsive disorder, right? The unique thing about this particular module of clinical psychology compared to the other 3, organization, health, and consumer, is it's very organized in its structure, which means that all 5 chapters are following a certain sequence of sections which make up the entire chapter. So by that I mean you can expect the same 3 sections to be this. You can expect the 3 sections to be the same in all of these 5 chapters. So you can have a diagnostic criteria section, which is the first part, where you're explaining the characteristics of the disorder according to what the International Classification of Diseases 11 is stating. You are understanding the different types of that disorder, ways of measuring the disorder, and so on. So that falls under the diagnostic criteria or the diagnostic guidelines. So that's always the first section of any chapter in clinical psychology. The second chapter is going to be explanations, okay? And in the explanations, it's usually broken up into biological and psychological explanations. So you have the role of genetics or different hormones, neurotransmitters in and how they have a role to play in a certain disorder. And then you have the psychological explanations, which has got to do with your thinking or your behavior. So that's how the second section is split up. And then finally, you have the third section, which is the treatment and management of the disorder, which is also typically split into biological and psychological treatments, where psychological is almost always a form of CBT therapy, and the biological treatments are mostly the use of drugs. Right? So this chapter is no different. We're beginning with the diagnostic criteria. Now, when we say diagnostic criteria or diagnostic guidelines, we're referring to, as I said earlier, the way in which we can identify the symptoms or the characteristics of a disorder. And this is important because a lot of disorders have overlapping symptoms, right? It's very difficult to differentiate between impulse control disorders and OCD. It might be difficult to differentiate between autism and OCD because both involve repetitive behaviors. So it's, at times when you have depression, it's coupled with anxiety as well. So for that reason, you need to have a certain set of guidelines that help you differentiate one disorder from the other. And that is explained by the DSM or the ICD-11, which are the manuals that help explain the criteria that needs to be met for each disorder. Okay, so the characteristics, the symptoms, the types, as well as ways to assess and measure the symptoms and the severity of a particular disorder. And at times they can ask you the strengths and weaknesses of this. So, it's very standardized. The ICD-11 is standardized. It's a very valid diagnostic tool as well. So you can make a valid diagnosis of a disorder in order to treat the patient correctly and the correct medication or whatever preferred treatment style that the individual goes for. But you can come up with the appropriate treatment once you have a correct diagnosis. And the correct diagnosis will only be made once you know exactly what the symptoms and characteristics are of a disorder. And that is very well explained in the diagnostic guidelines of a disorder, which is why it's quite valid. So, what does the diagnostic criteria say for impulse control disorders. So according to the ICD-11, impulse control disorders are characterized by a repeated inability to resist the impulse or urge to carry out a particular behavior. So it's pretty much like an addiction. You cannot resist the urge or the impulse. Impulse is an urge. You cannot resist the urge to engage in a certain behavior. And the reason for that is because that particular behavior is giving you gratification, it's giving you pleasure, it's giving you joy, it's making you feel good. And obviously, everyone wants to feel good, right? So if there's a particular behavior that's making you feel that way, you would want to engage more and more in that. But it can be problematic when it's the main priority of your life to the extent where it's all you can think about. It's you spending most of your day, most of your time not only thinking about it, but engaging in that behavior or activity. And as a result, it hinders your relationships with your friends, with your family, your professional relationships as well. So obviously, it's not the ideal situation to be in, right? It's okay to have hobbies. It's okay to be, you know, it's okay to like coffee, for example, but having coffee, 5, 6, 7 times a day, or maybe more, after every 2 hours, perhaps, maybe that's going a bit overboard. And obviously, it has its consequences. Okay. So everything needs to be in moderation. But when you do a behavior excessively, to the extent where it starts to affect your life and allows you to no longer function properly, then it becomes an issue. So even though the behavior feels rewarding in the short term, in the long run, it can have negative consequences. Okay, for example, self-harm. For example, tarnishing your relationships with your family, friends, loss of employment, right? So it can affect you personally and professionally. Okay. Let's take a look at some of the types of impulse control disorders. There are quite a few, but in our syllabus, we are concerned with three. The first one is kleptomania. Many of you may have heard of this term before. Uh, Considering you've done your paper 3 right now, you all should have heard of this term right by now. If you don't know what kleptomania is, then well, there's always the October-November exam. So kleptomania is one form of impulse control disorder. It refers to an inability to resist stealing objects that are not stolen for their monetary value or personal use. So a kleptomaniac is an individual who likes to steal, but a kleptomaniac stealing is different from the stealing of a robber, okay, a thief, because the latter would be stealing for personal or monetary gain, right? Why do people steal? They steal because they want to maybe use something, maybe use that item that they've stolen for themselves, or they want to resell it and get some money out of it, right? That's how it works. But if you're stealing not for any monetary gain, you're not stealing for the monetary value of that object that you've stolen or for any personal gain. And the only reason you're stealing an object is because the act of stealing itself is what's giving you pleasure, then it's probably a sign of kleptomania. All right. And the evidence of this is kleptomaniacs at times will steal objects that they may not even need themselves. They won't resell it, they'll keep it. They might not even keep it, they might disregard it. Um, but they have no need for that particular object that they've stolen. So why do they steal it? So like I said, it's got nothing to do with the object. It's the act of stealing that gets them really excited. It brings them a sense of gratification and satisfaction. And before they commit this act of stealing, they will go through extreme levels of anxiety because they know what they're doing is wrong. They know that if they get caught, there will be consequences. So there is awareness over here. Okay, it's not like they're unaware of what they're doing. They know full well what they're doing is wrong, that there will be consequences, but they can't stop themselves from engaging in this behavior. That's why it's an impulse control disorder, right? Understand the word impulse control disorder. It's a disorder where you cannot control your impulses or urges. So if you have an urge to steal something because you know it's something that will excite you, you know it's something that will bring you satisfaction for whatever reason, right? Maybe someone who's not a kleptomaniac may not understand why stealing is something that might get you excited, but for a kleptomaniac, in their minds, it is something that brings them a lot of joy and excitement. So they want to engage in that behavior. And even though they know it's wrong, they will not be able to stop themselves from stealing. So um, it appears that this disorder is more common among women than men, but one reason for that is maybe due to the fact that women are more likely to actually seek treatment than men, perhaps more recorded cases of women than men. It's not very common in the population, and there's around only 0.3 to 0.6% of the population that can often be diagnosed with this disorder. Okay. It can hinder your ability to concentrate because obviously, if you're at work and all you can think about is stealing something, then you're not going to be concentrating on your work, are you? It can make you feel a sense of guilt or shame because you are aware that what you're doing is wrong. And it can even lead to arrest if the behavior goes out of control. So if you know, do it a bit too much, perhaps a time will come where you will be caught, and then you might have a criminal record to your name, which is obviously not something you'd want. And then obviously there are consequences associated with that, like losing your job and affecting your personal and social life as well. So, in order for you to be diagnosed with kleptomania, it's important that it cannot be attributed to any other mental or behavioral disorder. So, it should not be explained by any other type of disorder, like OCD. Okay. So you need to be sure. That's why you have the diagnostic guidelines to make sure you're not mixing up different disorders. So it should not be better explained by another disorder, and it cannot be due to substance abuse. So you're not doing this because you've had a lot to drink or you've just taken some drugs and then you're doing it, right? The person is they've not been abusing any substances. This is just something that is, like I said, they're aware of what they're doing. Okay, so it can't be due to intellectual impairment either. So they're fully aware of what they're doing. They know what they're doing is wrong, and they just cannot resist the urge to do it. That is kleptomania. Let's take a look at the other, which is pyromania. Okay, this is an uncontrollable impulse to start fires. So, pyromaniacs are those people who have this uncontrollable urge where they cannot resist this urge to set things, property, or items on fire. Right, and you can only be diagnosed with pyromania if you've intentionally started fires on more than one occasion. And starting fires over here does not mean that, it's um, like a wedding or a birthday and you're, setting some fireworks. That's different. You're doing that with a particular purpose, which is to enjoy, and it's for an event. A pyromaniac will set items on fire, similar to kleptomania, because it brings them joy and it brings them excitement. And just like in kleptomania, you will experience extreme anxiety before the act, but once you engage in the act of setting the item on fire, it'll bring you a sense of excitement and gratification afterwards. So, pyromaniacs are often fascinated by fire as well as accelerants such as gasoline. They may even take up some voluntary work where they're close to fire, such as um, working as firefighters, or where they're constantly in touch with fire, or maybe setting up like fireworks, etc. um, some people with pyromania are indifferent to the destructive consequences of starting fires, whereas others have reported feeling extreme distress. So it's different from person to person. Some people don't really care too much about the consequences of their acts, and they're not too worried about that, whereas others are extremely distressed by their behavior, and they know what they're doing is harmful and can have consequences not only to themselves but others as well. And similar to kleptomania, in order for you to be diagnosed with pyromania, the symptoms cannot be explained by any other mental or behavioral disorder, substance abuse, or intellectual impairment. And one last point I'll say about this, again, it's not for any personal gain or the purpose of revenge. Okay, the only reason you're doing or engaging in this behavior of setting items on fire is because it just brings you excitement. And the third type is gambling disorder. Gambling disorder is also referred to as pathological gambling, and it is a persistent or recurring gambling behavior either online or offline. So it's just a constant need to gamble. So persistent means you've been doing it for a while, and recurrent means maybe you stopped in the middle, but then you began it again after a while. And online, offline means you can be doing it, placing bets over the internet, or you could actually go to the casino and engage in gambling. It is characterized by impaired control of gambling in terms of the length of time spent gambling or the amount of time spent gambling. So the individual cannot really resist the urge to gamble in terms of how much money they're spending and how much time they're spending gambling. So someone with pathological gambling may be spending hours and hours or all day at the casino. They might be spending a lot of money, they might be losing a lot of money, they know that there are consequences, but they'll still continue to gamble. And they'll give priority over to gambling over other areas of their life, which will obviously affect their personal life and their professional life. Because just like any other impulse control disorder, if this is all you can think about, and this is the only thing you can engage in, then it will affect your relationships with others. And the individual will want to continue to increase their gambling behavior even though there are negative consequences. Okay, and negative consequences over here doesn't mean just losing money. It means losing your job. It means hindering or tarnishing your relationships with your family and friends and so on. And in order for you to be diagnosed, the symptoms must be there for at least 1 year, but this can be lower depending on person to person, okay, depending on the severity of the symptoms. So these were the three ways or three types of impulse control disorders that are part of our syllabus. And we usually discuss a particular measure, self-report questionnaire that helps us assess the severity of the symptoms of one of these types of disorders that you find in different chapters. So over here, we're looking at the assessment of kleptomania's symptoms and severity of symptoms. So the assessment is a questionnaire. It's a self-report questionnaire, close-ended. It's called the Kleptomania Symptom Assessment Scale. You are not required to necessarily write the whole term. You can just refer to it as the KSAS. This has 11 items where the individual rates the 11 items themselves. So it's a self-report, and it's measuring your impulses, your thoughts, your feelings, and behaviors towards stealing. So obviously, by the term you can tell it's an assessment of your kleptomania behavior. However, it's assessing your kleptomania urges within the past 7 days. So it's not what you're feeling today, but how you felt within the past 7 days with respect to any urges to steal. Each of the 11 items will be rated on a scale of 0 to 4 or 0 to 5, with 0 being no symptoms and 4 or 5 being severe symptoms. And obviously, the higher the score, the greater your severity of symptoms. And here's an example of one of the 11 items. If you had urges to steal during the past week, on average, how strong were your urges? Please circle the most appropriate number. 0, none, while mild, 1 mild, 2 moderate, 3 severe, and 4 extreme. Now, what should you know about this? You should know how many items there are. You should know what it's assessing. You should know some strengths and weaknesses of it as well. Okay, so what are the strengths and weaknesses of a close-ended questionnaire? Well, for one, it's standardized. Okay, it's the same questions being asked in the same the same rating scale for all participants. Um, it's close-ended with a rating scale, so you can collect quantitative data and you can compare not only the severity of one patient to another, but the same patient over time. So if I want to treat you for your kleptomania, I can use this to assess what your severity is like before treatment, and then I can give it to you again and see if there are any changes post-treatment. Weaknesses would be that it's lacking qualitative data because there are only close-ended questions, which are on the rating scale from 0 to 4 or 0 to 5. So it lacks qualitative data. And with any questionnaire, there's always the possibility of social desirability bias, where the participant or patient may not necessarily be truthful with their responses. So that is the first section of this chapter complete, the diagnostic criteria. Let's move on to the second one, which will be the explanations of impulse control disorder. So under explanations, we're understanding what causes the disorder. And as I said earlier, you have biological and you have psychological explanations. Under the biological explanation, we have only one, which is a biochemical explanation. And biochemical over here refers to the role of neurotransmitters or hormones or chemicals in your brain, one of which is dopamine. Okay, dopamine is a very important chemical. It's also at times referred to as a happy chemical, and it plays a role in many disorders, schizophrenia, in mood disorders, OCD and in impulse control disorders as well. So let's see how it affects people with impulse control disorder. Now, when someone with an impulse control disorder engages in the behavior that they find enjoyable, that gives them satisfaction, it feels rewarding to them, right? So when someone feels a sensation of reward or gratification, dopamine is released in the brain, okay? Specifically where the reward center of the brain, which is referred to as the striatum. So when someone, for example, someone who's got pathological gambling, when they gamble, their reward centers become stimulated and dopamine is released over here in the striatum, right? So this is the part of the brain that is responsible for you feeling the sensation of reward. Every time you feel rewarded for showing a behavior that gives you gratification, um, your striatum is the part of the brain that is getting stimulated and it's releasing dopamine. Okay, so when you engage in behaviors such as stealing, setting fires, or gambling, and when it becomes compulsive, you build a certain level of tolerance, which lowers the dopamine levels in the striatum. So what's happening over here is the first time you, or the first few times you gamble, the striatum, which is the reward center, gets stimulated because you feel mentally, physically, emotionally that you're getting rewarded, right? The reason for that is the striatum, when I say it's getting stimulated, it's releasing dopamine. Dopamine is a happy chemical. So when dopamine is being released in this part of the brain, then that means you are feeling a sense of reward, you're feeling a sense of gratification in that behavior that you're doing. So you want to display more of that behavior. For example, if it's gambling that's making you feel this way, you want to gamble more and more, right? However, after a while, you build a certain level of tolerance. For example, if you've been gambling for 4 hours a day and it was giving you a certain level of um, sensation of reward where your dopamine was increasing, after a while, those 4 hours are not giving you that same level of dopamine boost that you were initially getting. So you've built a level of tolerance. So it's not the same level of gratification as it was initially. So in order to increase these dopamine levels, what you will do is you will increase the frequency of that behavior. So if you were previously getting enjoyment from 4 hours of gambling, to get that same level of enjoyment now from four, which you were from four, you might have to increase it to six. And once you build a certain level of tolerance to 6 hours, then it'll move on to 7 and 8 and so on. So that's how dopamine plays a role in the onset of impulse control disorders. And this is referred to as the reward deficiency syndrome. After a while, you feel that sensation of reward diminishing. So in order to get that same level of excitement that you were getting initially, that same gratification that you were getting previously, you would have to increase the frequency of the behavior that is giving you the sensation. And that's how it eventually becomes an impulse control disorder. The psychological explanations involve two. The first one is the behavioral explanation or positive reinforcement, very closely linked to the dopamine explanation that we just discussed, but we'll look at it from a behavioral perspective now rather than a biological perspective. So positive reinforcement is a part of operant conditioning, and positive reinforcement is, in other words, just the same as reward, right? So when you reward someone, when a behavior is rewarded, it is likely to be repeated. Okay, so if a person gambles at the casino for the first time and wins, the winning prize would act as a positive reinforcer, and this would urge the individual to repeat the behavior. Right? You go to the casino, you gamble, you win some money, you feel rewarded, right? Biologically, the explanation is that the striatum is releasing dopamine, but behaviorally, the explanation is that you feel good, you feel rewarded, you want to display that behavior more. Okay, you obviously enjoyed it, you want to experience it again and again and again. However, at times, what happens is, let's take gambling for example. You may not always be rewarded, right? Yes, there are some behaviors such as setting things on fire, stealing items. Every time you display it, it'll give you a sense of excitement. So you want to display that behavior more and more. And when you display that behavior more and more and more, it becomes compulsive, which turns it into an impulse control disorder. But at times, there are certain behaviors where you're not always going to get rewarded. And gambling is an example of that. When you gamble, you're not always going to win. Let's say you go to the casino for the very first time and you win big. You will be rewarded, obviously. You will feel a sense of gratification and excitement, which you probably haven't felt before. You enjoy that behavior, you want to repeat it, right? Right now, it's not problematic. But when you repeat it, you might lose out on some money because you don't always win, right? The more chances of you losing than there are of you winning. So, yes, you might have won the first time, but then the next time you play, you lose money. Now, in order to try and win back the money you just lost, you'll play a third round, and then a fourth round, and then a fifth round. So you're not always going to be winning. There will be chances where you will be losing out on money, and that'll cause you to want to continue playing with the hope that the next turn that I play could be the one where I win big. So the rewards aren't continuous over here, they're intermittent. We refer to this as partial positive reinforcement or schedules of reinforcement, which means you're not always going to be rewarded. And it makes sense because if you're always rewarded, then it'll become boring, right? If you're always going to win, if you're always going to be rewarded for a behavior, then a certain level of tolerance will build up and it won't excite you as much. But in gambling, you're not always going to win. You win once, it brings you a sense of excitement, you want to feel it again. But because it's so elusive, this feeling of winning in gambling, winning big in gambling, you want to experience it again, that you don't mind displaying that behavior again and again and again and continuously gambling again, even though you're losing a lot of money, because you're always going to be thinking that the next time I win, next time I play, is probably the one where I win big. And if you do win, then it will bring you a great sense of satisfaction, perhaps even more than the first time, right? So it's this intermittent reward um, system in a way that you can say is causing you to continue the behavior. Okay, almost like that feeling of the unknown where it's the next turn where I could possibly win big again, that causes you to continue playing with the hope that, I will probably eventually win. So I get that level of excitement that I got the first time I won. So that can lead to this behavior becoming compulsive. Okay, let's take Okay, let's look at the cognitive explanation now. This is the second psychological explanation, and it's the third explanation overall. It's by Miller. It's called the feeling state theory. And cognitive obviously means that we're now going to be looking at the role of the individual's thinking that could cause them to develop an impulse control disorder. So, in the feeling state theory, Miller is going to be talking about underlying thoughts about certain behaviors that explain obsessions, right? So because you're obsessed with a certain behavior, there are certain underlying thoughts about that behavior that make you feel a certain way that cause you to become addicted to it. So in the feeling state theory, we are going to be talking about how you have how an individual has these really intense positive feelings that they link with certain behaviors. For example, gambling. There is a certain intense positive feeling that an individual links with gambling, which makes them want to display that behavior more and more. So this link that develops in a person's mind, okay, in the gambler's mind, with the link between the gambling behavior and that positive experience of gambling, it's basically called the feeling state. Okay, it's a certain mental state that the person wants to be in. It's basically their perception of how a certain behavior brings them a sense of excitement, all the positive sensations, all the positive emotions that they have with regards to a certain behavior. So like someone who steals, for them, the idea of stealing, they've got some, it brings them a sense of satisfaction, it brings them a positive sensation, it uplifts their mood. So all these positive thoughts, emotions, memories, and sensations are linked to the behavior of stealing. And this is all in their mind. Okay, so we refer to it as a feeling state or a um, state dependent memory. Okay, because it's a memory of an event that they perhaps for the first time they set something on fire, for example, a pyromaniac. They remember the times where it made them feel good, it made them feel powerful, for example. So that sensation, that positive sensation of feeling powerful, which they associate with setting things on fire, is their feeling state. Okay, they want to be in that mental state. They want to be feeling that positive sensation all the time, which is why they'll be engaging in the behavior of setting fire more and more, right? Now, why to be doing this? Why do they feel this way? So obviously it's for them very positive, right? It's not only positive mentally but also biologically, because their heart rate increases, their dopamine increases as well. So that's biologically explaining why they feel so good. But when they engage in the behavior of stealing or setting things on fire or gambling, it makes them feel a certain way which they wouldn't feel otherwise. At times it makes them feel powerful. For example, let's take an actual example of a pyromaniac. Okay, a pyromaniac may be setting things on fire because the positive sensations, the positive emotions that he associates with setting things on fire is a sense of power. So if I'm a pyromaniac and I'm putting things on fire, the reason I'm doing that is because it makes me feel powerful. So all those positive sensations that I'm feeling are basically associated with the sense of feeling powerful. So I'm associating the idea of being powerful with setting things on fire. And I like to feel that way. So I want to be in that state more and more. So I will set things on fire quite often. And that's how it becomes an impulse control disorder. However, Miller states that the reason people actually are doing something like this is because deep down there are actually some underlying negative thoughts that the person has about themselves. So these underlying negative thoughts or experiences are what are really shaping these behaviors. So if I'm setting things on fire because it's making me feel powerful, the only reason I'm doing that is because deep down I actually have perhaps a very negative perception of myself. I have some underlying insecurities where in reality, deep down, I might be thinking I am actually quite weak. And I don't like to feel that way. I don't like to feel this negativity of me being weak. So, what I will do is I will engage in a behavior that does not make me feel that way. I will engage in a behavior that mentally makes me feel good about myself, makes me feel powerful. And in my case, setting things on fire does that because I'm a pyromaniac. I'm not actually a pyromaniac, I'm just giving a hypothetical example. So if I set things on fire, then it no longer allows me to feel insecure about myself. It no longer allows me to feel weak. But instead, during the time where I put something on fire, I feel powerful. I feel in control. I feel positive. I feel all positive sensations and emotions. And that is my feeling state. And I want to be in that state as much as I can. Right? So that explains why well, that explains how the feeling state is responsible for the development of different impulse control disorders. All right. Obviously, there are consequences. When you set things on fire, you feel powerful for that particular moment in time. But then after a while, for some people, you know, it may go back to phase one where they start feeling worthless again or start feeling weak again because they realize the consequences of their actions. They realize, I've set things on fire. I felt great while I was doing it, but after some time has passed, I might realize what I've done is actually quite wrong. And then it goes back to me thinking, why did I do this? Again, just developing a very negative perception of yourself. I mess up everything. Um, you know, I'm weak, I'm useless. Just all those negative underlying thoughts come back to you. And then when you get stuck in this spiral, again, you don't want to feel that way. So then later on, again, you start setting things on fire because you want to feel positive again. You want to be in that feeling state again. And then they just continue. So that's basically the explanation of how, or the cognitive explanation of how the feeling state theory can lead to impulse control disorders. Okay, now let's talk about the treatment of impulse control disorders. We'll start with the biological treatment. This is actually a key study by Grant in 2008, where we're using drugs referred to as opiate antagonists to try and treat gambling disorder. All right. Now, what are opiate antagonists? They're a group of drugs, and they've often been used to treat substance abuse. Okay, so when someone is suffering from substance abuse, they're often given these drugs because what it does is their reward centers get stimulated. So we discussed in the explanations that when you're engaging in a behavior that brings you satisfaction and gratification, then your reward centers get stimulated, and that will urge you to engage more and more in that behavior. So these particular drugs, they block the reward center, and they stop the individual from feeling that um, sensation of gratification that they normally would. So they it stops them from craving the particular behavior. So we're going to try and see over here how these opiate antagonists will um, block the individual's reward center and reduce their urge to gamble. Now, an interesting thing about the study over here is Grant is hypothesizing that people who have a family history of alcoholism, okay, the people with pathological gambling in the study who also have a family history of alcoholism, they're the ones who are actually going to see a greater reduction in their symptoms um, from higher dosages of higher dosages of opiate antagonists. Okay, because alcohol and gambling often work alongside each other. So it's quite common to see someone with pathological gambling also having a family history of alcoholism. So in this particular study, we want to see if those people who do have a family history of alcoholism who are also pathological gamblers, if the opiate antagonists would work better on them, especially in higher dosages, right? Previous studies by Kim have shown that opiate antagonists can be a successful treatment for pathological gambling. However, this differs from from person to person, so it can be very different for different people, and that's the case with any drug. Right? This is true to literally any medication, where it does not have to necessarily work the same way for everyone. Some people experience more or less side effects than others. Some people have a certain level of tolerance to some medication, others do not. So the success rate can vary from person to person for this drug in treating gambling disorder. And as I said, Grant hypothesized that a family history of alcoholism and stronger urges to gamble would be associated with positive outcomes for those treated with and opiate antagonists. Right? They also hypothesized that people with less severe pathological gambling would be more likely to respond positively to a placebo than those with more severe pathological gambling. So a placebo is going to be like a control condition. It's in most cases a saline solution, and the participants will not be told that they're getting a placebo, okay, because we don't want any demand characteristics. So those with a less severe case of pathological gambling, they might be more likely to see an improvement in their condition by being given a placebo. So basically, like a psychological impact would happen for them, because a placebo is not going to biologically do anything in terms of treating their addiction and treating their compulsive behavior. But just thinking that they're getting a drug psychologically may help reduce their symptoms. But the idea over here, the prediction is that this would only work on those with a less severe case of pathological gambling, not so much on those with severe case, a more severe case of pathological gambling. So the really severe pathological gamblers, the placebo will not work on them. On them, it will be the opiate antagonist that will be more successful. So let's check this hypothesis out. It is a double-blind technique, so neither the participants nor the researchers know if the participants are in the placebo condition or in the opiate antagonist condition. And two different trials will be conducted, where in one trial, participants will be given one type of opiate antagonist and they'll be compared to a placebo group. And in the other trial, there'll be another type of opiate antagonist and they'll also be compared to a placebo group. So essentially, we have four groups over here, and it's an independent measure design. Now, what are the two opiate antagonists that are going to be given? One is going to be called nalmefene, and the other is called naltrexone. Okay, so these are the names of the medication. These are the two names of the two opiate antagonists that we're giving. So if anyone's confused, let me just quickly recap. We are assessing if these particular drugs that we call opiate antagonists are going to be helpful in treating people with gambling disorder, because this drug is known for blocking the reward center, which is something that gets stimulated when people gamble. So by blocking the reward center, perhaps it will reduce an individual's craving to want to gamble. All right. But the hypothesis over here is that it will be more effective on people who have a severe case of pathological gambling as opposed to those with a less severe case of pathological gambling. And at the same time, it will be more effective on those with a severe case of pathological gambling who also have a family history of alcoholism, because alcoholism and pathological gambling often go hand in hand. Okay, you'll often see someone who's a pathological gambler also having a family history or a personal history of alcoholism. So we believe that by giving the participants with the severe case of pathological gambling and a family history of alcoholism, the opiate antagonists, they are going to experience a significant reduction in their symptoms, much more so than those who have a lower severity of pathological gambling. And the way we're going to be doing this is half the participants will be given the opiate antagonists and the other half will be given a placebo. And another prediction is that the ones being given the placebo are actually psychologically going to see an increase or a reduction, sorry, in their symptoms and an improvement in their condition, only if they have lower levels of pathological gambling. So the placebo should benefit them and work on them, but it won't work on those with a severe case of pathological gambling. Okay, for them it'll be the drugs that will work. What are the two drugs? One is called nalmefene, one is called naltrexone. Okay, so we've got four groups. One group will be given the nalmefene and they'll be compared to a control group. And then there'll be another group will be given the naltrexone and they'll be compared to a control or placebo group. Okay, and the first experiment where you're comparing the nalmefene to the placebo will be for 16 weeks. And the other one where you're comparing the naltrexone's effectiveness to the placebo will be 18 weeks. And like I said, it will be a double-blind technique. It's being done on 284 patients who have pathological gambling, and they've had the urge to gamble or they have gambled within the last 2 weeks. It's an even mix of males and females, and they're all from the US. So the participants who are being given the nalmefene are going to be given dosages of either 25 mg a day, 50 mg a day, or 100 mg a day, depending on the severity of their symptoms. And they'll be compared to a placebo group who will be given the same amount as well. And in the other trial, the one who are given naltrexone, those participants are going to be given either 50, 100, or 150 mg per day, and they'll be compared to a placebo group as well. How many of the participants are getting a placebo? Approximately 25% of the participants are being given the placebo. So majority of the participants are the ones who are actually going to be given the naltrexone or the nalmefene. Now, once the participants are given the drugs during the course of this study, we want to assess if their symptoms are going to decrease or not. And the way to do that is through a self-report. The self-report being used is the PG Y-box. Now, the Y-box is a self-report questionnaire that is used in assessing obsessive compulsive disorders. And this is obviously not the chapter on OCD, this is ICD. But because, like I said, there are similarities, because both involve obsessive thoughts and compulsive behaviors, the Y-box is going to be used over here to assess the symptoms of pathological gambling. But the Y-box is not used only for assessing gambling disorder, right? The Y-box, which we'll cover in more detail when we do the chapter on OCD, has 10 items, and it's you can get a score from 0 to 40, and it's assessing different types of obsessive thoughts. It's assessing different types of compulsive behaviors, right? So it's basically a measure of different types of OCD behavior. In this study, we're not concerned with OCD, or we're not concerned with any type of obsessive thought or compulsive behavior. We're concerned specifically with gambling disorder. So they modified the Y-box in such a way that it is assessing only symptoms of pathological gambling, which is why the questionnaire that is being used over here is called the PG Y-box. Okay, so the Y-box modified to assess only for pathological gambling symptoms. Now, along with this questionnaire, we are also assessing their anxiety levels, their depression levels, and their general psychological functioning levels through other types of questionnaires and self-reports. Okay, semi-structured interviews were also conducted to get a family history, especially first-degree relatives of the patients with alcoholism. So this is how we are finding out if they have a family history of alcoholism. What were the results? The participants who were given the nalmefene or naltrexone compared to the placebo group had a significant reduction in their symptoms. Okay. However, there were individual differences between the groups. Participants with a family history of alcoholism and those who received the highest dose of opiates showed the greatest reduction in gambling disorder symptoms, which suggests that opiates are more effective in some gambling addicts than in others. So basically, what Grant hypothesized, what he predicted, came true. He predicted that those who have a more severe case of pathological gambling and also have a family history of alcoholism are the ones who would benefit the most from higher dosages of the opiate antagonists. And that's exactly what we saw. The participants with a lower severity of pathological gambling actually benefited from the placebo, okay, much more than those with higher pathological gambling symptoms. So what we predicted basically came true. Um, However, there were some people who were excluded from the study, and these would be people who are infrequent gamblers who don't really meet the criteria of the DSM to be categorized as someone with gambling disorder. If you've previously taken these two medications, nalmefene or naltrexone, then you cannot take part in the study. If any of the participants were taking any type of medication that may interact unfavorably with these drugs, then you would be excluded from the study as well. You can maybe learn like two or three of these because even though it's not in the textbook, question did come in one of the past papers asking two criterias which may have excluded participants from the study. So to conclude, um, the opiate antagonists were successful in treating gambling disorder, particularly people with a high severity of gambling disorder or pathological gambling who also had a family history of alcoholism, right? So higher dosages work better on people with a more severe case of gambling disorder and family history of alcoholism compared to people with a less severe case of pathological gambling. Um, Psychological treatments now, there are two, and they're both forms of CBT, okay, cognitive behavioral therapies. The first one is covert sensitization, and the second one is imaginal desensitization. Let's take a look at the first one, covert sensitization. This is a case study, it's an example study, but you should still know it. For paper 4, you should focus on both example studies and key studies because a question will definitely come on the key studies. Okay, the first question is always going to be on a key studies. We don't know which one. It could be either on Grant this year or it could be on the study by Lavelle, where they're comparing the effectiveness of CBT offered via telephone to face-to-face. So do focus on those, but the example studies are equally important as well. Okay, they would ask you to maybe design a study to compare or to look at the effectiveness of covert sensitization in treating pyromania in a patient, for example. So what is covert sensitization? This is a form of CBT or treatment that is often used to try and treat people with impulse control disorders such as kleptomania. And it's based on the concept of classical conditioning, which is learning through association, okay, where the therapist will try to train the patient to associate a negative stimulus with the undesired behavior. So if the undesired behavior is stealing, okay, for kleptomania wants to get treated for the stealing behavior, then in this form of therapy, this form of treatment, the therapist will try to get the patient to associate the idea of stealing with something negative, such as nausea, right? So every time you think about stealing, every time you get the urge of stealing, you will be trained to associate it with a feeling of nausea, and hopefully that will reduce your urge to want to steal. Okay, so this is a case study that we're going to be looking at by Glover in 1985. It was on a 56-year-old woman who had kleptomania. She had some personal issues, some family problems. She had a 14-year-long history of daily shoplifting and was seeking treatment for it. Her husband was convicted of embezzlement and she took up a low status job. She became socially isolated and she fell into depression. Okay. Um, she would have these compulsive thoughts of shoplifting and she found them repulsive. She didn't want to engage in it, but she couldn't stop herself from doing it. So she could not resist the urge to steal items, even though she didn't want to. Now, the items that she would steal would be items such as baby shoes, even though she had no one to give them to. So she was not shoplifting for any personal gain. So she fits the number one rule for kleptomaniac. Then she decided to seek treatment from Glover. Now, there were a total of 4 sessions, which were at 2 weekly intervals. And the first 2 sessions involved her going through a muscle relaxation technique. Okay, so it involves basically teaching the patient to become completely relaxed, because covert sensitization uses visualization, it uses imagination. So, in order for you to be completely immersed in this imagination that you're going to be going through during the therapy, you need to be completely relaxed. So, technique of muscle relaxation is going to be used to help you be completely relaxed so that you can be immersed in the imagination. Now, the way that you can experience muscle relaxation can be through either medication. Okay, you can be given like an anti-anxiety drug, through visualization exercises, or maybe even repetition of calming phrases. So different techniques can be used depending on the patient, whatever they prefer, as long as they're able to completely relax themselves. Okay. Progressive muscle relaxation is often also used, where you're taught to progressively and gradually relax your muscles from head to toe. So beginning with your head, just completely relax your head, your face, your shoulders, all the way down to your toes. So bit by bit. That's why it's called progressive muscle relaxation. And once this has been taught, then the other 2 sessions will involve the aspect of classical conditioning, where we're going to try and get the patient, in this case, this woman, to visualize a scene where she is shoplifting, and we want to try and make her pair the idea of shoplifting with nausea. So she's going to be asked to imagine a scene where she is going to be shoplifting, and then she's attracting attention and disgust from others around her, and then she has to imagine herself vomiting or feeling a sense of nausea every time she's going through this experience. Okay, she's not only doing this during therapy, she's been told to practice this as homework as well at home. So just sit, completely relax yourself, then imagine yourself in a scenario where you're about to steal and you're attracting attention from other people. They're feeling disgusted by your behavior. You are disgusted by it. You want to puke. You start vomiting. And the more you do this, the more you actually trick your mind into believing that this behavior of stealing is actually very repulsive and it's going to cause me nausea. So the reason this is classical conditioning is because there is an association being developed over here. The association is between the undesired behavior of stealing and an undesired negative outcome of nausea. So every time you think of stealing, it's going to want to make you vomit. So that's the idea behind this form of treatment. So let's see. During the last session, she imagined the sickness going away as she replaced the item and walked away without shoplifting. So she picked the item up from a shelf in her head. It would make her feel disgusted. It would make her feel like she wants to vomit. And she says towards the last few sessions that when I imagine myself putting the item back on the shelf, putting it back away and not stealing and walking away, I felt good. I did not feel that nausea. So she was able to associate nausea with an undesired behavior. And as a result of that, she was able to overcome her impulse control disorder. Because when someone has this urge to do something in an impulse control disorder, and when they're denied from doing it, it causes them a lot of anxiety, it causes them a lot of frustration, right? So she reached a point where she was able to not want to steal. She was able to walk away from the thought of stealing and not feel anxiety. And in fact, the idea of stealing, in fact, was something that made her feel disgusted and made her feel like she wants to vomit. So she learned to associate the unpleasant sensation of vomiting with the undesirable stealing behavior. And at a 19-month follow-up, she had a very low desire to want to steal and very high avoidance to shoplifting. Just one single relapse, but overall, her condition had completely or significantly improved. Her overall self-esteem also improved. Her social life also improved. So, by treating this disorder of hers, it affected her life, other aspects of her life in a very positive manner. And the last psychological treatment is that of imaginal desensitization. Now, this is by Blashinsky and Noer, and this is also similar to covert sensitization, where you have to use your imagination, But the difference here is there is no classical conditioning involved. You're not pairing a negative outcome with an undesired behavior. But there's still a need for a visualization exercise where you have to use your imagination. So again, in order to be completely immersed in that imagination, there will be a need for muscle relaxation as well. So the first step is progressive muscle relaxation. So the patient has to visualize themselves being exposed to a situation that could potentially trigger the impulsive behavior, such as gambling. So imagine yourself, therapist will ask you to imagine yourself in a situation where you are about to gamble, or in a situation that will trigger the need to engage in gambling, if that is your compulsive behavior. Okay, so visualize that. Then you will be asked to imagine that you're coming back home from a long, stressful day at work, right? So obviously, it's been a long, tiring day at work. You have to imagine yourself going through that, and the only thing you can think of to give you some relief um, is going to the casino or just going online and gambling, right? They are then asked to imagine acting on the impulse to gamble. So now you're mentally telling yourself, you know what, I want to go and gamble now because I've had a long, tiring day. So I just want to relax. I want to go and gamble. And, that will cause you a bit of excitement. But then mentally, as you're imagining yourself getting prepared to want to go and gamble, the therapist will now ask you to mentally walk away from that situation. All right. All of this while going through the relaxation technique. Because in your head, if you've got a gambling disorder and you've mentally thought about going to gamble, it will excite you. So if someone tells you now to mentally just walk away from it, it'll cause you anxiety. But by going through a muscle relaxation technique while imagining all of this, it'll help reduce the anxiety and make it slightly easier for you to imagine yourself walking away from the need to gamble and not feel as much anxiety. Okay, so sessions are practiced. They may be audio recorded so that you can practice this at home outside the therapy sessions as well. This treatment therapy tends to reduce psychological and physiological arousal associated with gambling, such as anxiety, even over a long time period, as shown in a 5-year follow-up case study. So, a 5-year follow-up case study showed that this has been quite useful, where after a while, when you're able to mentally walk away from the behavior, from the compulsive behavior, you no longer feel anxiety. And as a result, you learn that I don't have to engage in this behavior. Okay, I can walk away. I don't have to necessarily display that behavior. I don't have to go through anxiety. So it's not just a short-term fix, like it says over here. There have been studies that show that this can work in the long run as well. Okay, 5-year follow-up has shown that someone who went through this, they not only reduced their urge to gamble in the short run, but 5 years later, they still had a very um, considerable improvement in their condition, and they were able to overcome their need and their desire or urge to gamble following this treatment, right? So that's the psychological treatment. Let's just briefly discuss some evaluative points of the treatment and management, right? If you would talk about the biological treatments, then in terms of the issues and debates, it's obviously going to favor the nature side of the debate because it's got to do with blocking the reward center. It's got to do with, you know, um, it's basically a drug, right? So it's affecting the neurotransmitters, the chemicals in your brain, the dopamine level, which is obviously going to be increased due to a need to want to engage in a particular behavior. So by blocking that, it's going to try and reduce um, that overall behavior. So you could say it's favoring the nature side, but obviously it's just one form of treatment, right, through drugs. And as a result of that, it can be reductionist. It might not be the most valid or the most accurate form of treatment because it can work differently for different people. As suggested by Kim, there's a 10 to 30% effectiveness rate depending from individual to individual. So we can link that to the individual debate as well. The individual situational debate, we can say that the individual explanation can be preferred because those with a higher severity of pathological gambling and those with a history of family history of alcoholism were the ones who actually benefited more from higher dosages. So that would naturally favor the individual side. Then we can talk about the application as well of the study. If you do have a very severe case of pathological gambling and you do have a family history of alcoholism, then these drugs might be more effective for you. right? So then a doctor could maybe, if they've diagnosed you with a severe case of gambling disorder, then these drugs could be applied to you. They could be quite useful and effective in treating your condition to by a considerable amount. Okay, other than that, it's an independent measure design. We can talk about how, through an independent measure design, there can be individual differences which can lower validity. That's a research method point that you can talk about. There's a self-report through the PGY box where they're collecting data about the severity of the symptoms, which is quantitative data. But then, there are always chances of socially desirable responses. So just, a mix of research method points that you could use as well as some issues and debates. For the two psychological treatments, one of them is a case study. So you could talk about the strengths and weaknesses of a case study. The study by Glover on one participant. So obviously it's lacking generalizability. It's an idiographic research because idiographic focuses on qualitative data. It focuses on um, unstructured self-reports and case studies on one single participant, which is what this study is, right? So it's not generalizable, and that would be the biggest weakness of it. Other than that, you can talk about the strengths and weaknesses of imaginal desensitization. Um, that and covert sensitization, both you can say have high applicability. All right, people on whom maybe the drugs are not very effective, for them, perhaps treatment is a better option. Perhaps you can build tolerance to the drugs. So maybe it's the drugs are just a short-term solution, and you want to control your impulse control disorder, in the long run as well. So CBT treatment, such as these two, can be more effective over a longer period of time, as have shown over here, right? 19-month follow-up for the woman in the Glover study, and in imaginal desensitization, studies have shown a 5-month follow-up that, in the long run, it's quite effective in reducing your compulsive behaviors as well. So just some points that you can keep in mind for evaluations, obviously not needed for P4. Um, but you should know some research method related points for P4, by the way. So that I'll discuss when I'm going to be posting a video on how to design a study. I have already posted a video on the structure for paper 4, how to attempt general questions in paper 4. So do take a look at that. I will return hopefully soon with a video on how to design your study in P4 and the questions that follow the design study in P4. You've got quite a few. So I'll discuss all of those in detail. But I'm going to try and also post videos on OCD, on pain, and on stress, because these are the 4 that are expected in your P4 paper. I probably will not be able to post videos on the other chapters immediately, and also on organizational psychology. That will be my focus maybe for the next academic year, and consumer as well. So for now, focus on these, and you've got a few days left for your P4. So try to study as much as you can for these 4 chapters. Okay. Hopefully back with more videos very soon, and hope this was helpful. And if you have any questions, feel free to comment below. As always, I leave my contact details in the description, so you can reach out to me. If you want access to these notes, then let me know. Email me, WhatsApp me, and I could send you my Google Drive where I have all my notes uploaded there for clinical psychology, for health psychology, and research methods as well, which is something quite important, especially for paper 4. All right, thank you guys. See you next time. Take care.